I'll start again because I had the microphone off. I just welcome everyone to the 61st Global Health History Seminar on chlamydia. And as we're broadcasting on the internet, I'd ask everyone when we come to the questions, which we'll take after the two speakers make their presentation, to give their name so that people can also follow from a distance. My name's Humon Moman, the coordinator of Who Press, and I welcome everyone here and on the internet to the seminar. Our first speaker is Professor Michael Worboys. He's a director of the Center for the History of Science, Technology and Medicine at the University of Manchester. His background is in biology, and from studying biology, he became interested in the history of biological medicine, and he did his PhD at the University of Sussex on the history of colonial science. He's recently written a book on the history of rabies, which has led to sort of current interest, and which you'll be talking about today. So I'd like to ask Professor Worboys if he would come and make his presentation. Thank you.
Okay, well, okay. I'd like to thank everybody who's been involved in inviting me today. It's very nice to be here, and I think it should be interesting to talk about chlamydia. This work comes out of not so much my rabies work, but my general interest in infectious diseases, and some work I did on gonorrhea and how gonorrhea from the 19th to the early 20th century moved from being a disease which was seen to only affect men to one that was equal in both sexes. And the chlamydia story was kind of similar. And I got interested as well, as we'll see in a moment, in the disease which kind of emerged from studies of gonorrhea in the 1930s and 1940s, which is this disease of NGU, non-gonococcal urethritis, which is an interesting disease because it's defined by what it isn't, and kind of how that condition gets unpacked is really my story. I begin with this. I thought I'd begin with this poster from California, because what it's telling you is that the chlamydia is not familiar. It's a term which isn't familiar to people. It's new. As this implies, many people think it's something you grow in your garden. There is a story that goes around the legal profession in Manchester about a couple who named their daughter Chlamydia, and then realized 6 months later and had to get her name changed and expunged from the birth certificate. I don't know if it's true, but it would be interesting if it was. But I think it is a new condition, and it's one that STI specialists are very concerned about. These are the figures from the UK of the reported incidence of STIs from 1998, where chlamydia is on the increase massively. It almost triples in incidence over a decade, and in terms of newly reported cases, it's greater than all the other STIs put together. So it's a really important disease in terms of incidence. But if you trace the red line back, which is the chlamydia line, it will only go back as far as 1993, because that is the first year of which there are official figures. And so the question I want to end up with is really, is this increase real? Is this, a genuinely new disease? Probably not. Secondly, is its incidence really rising, or does this increase merely reflect the fact that we're testing for it more with more sensitive and more specific tests. And that in the view of some STI specialists, I've suggested that probably this line, the red line, maybe ought to be a straight line, and that its incidence now is maybe no different to what it was in 1998, because if it is down to changes in sexual behaviour, unprotected sex, etc., then why isn't gonorrhea going up in the same way, which is a disease that would be transmitted in the same way? So I'll come back to that question, and some of the people here who work on STIs may know more about that than I do. And I should say that, kind of, as a largely historian of the 19th and first half of the 20th century, I'm on relatively unfamiliar ground here, because I'm talking about the second half of the 20th century, which for a historian is really quite recent, I have to say. If you go back to the history of venereal diseases, as they were then termed, until really 1930, there were only two. And indeed, for much of the 19th century, venereal disease was singular. People talked about venereal disease, and they meant syphilis. Venereal diseases came to be a term that was used in the first half of the 20th century to refer to syphilis and gonorrhea. And then in the 1940s, there was the really earliest reported recognition of other conditions. And this is the list that's in a 1944 textbook. And hidden away there in the middle is non-gonococcal urethritis. And then there's various other viral infections, warts, there's thrush. There's a whole variety of viral, bacterial, fungal infections in there. And McLachlan is really the first source that I found in 1944 that tries to unpack these other conditions. And I think quite significant, that the data is quite significant, because in the history of STIs, wars have been very important, because governments have invested in STI screening, STI diagnosis, STI treatment, because of fears about rates of invalidism amongst troops. And so you can trace the history of contagious disease controls in Britain goes right back to the 1860s and attempts to control it in the military. The services are ramped up in the First World War and after the First World War, and this is beginning to reflect that. So you get war and invalidism, and the sense that many of these diseases are being caught in the tropics and brought back to Europe and to North America. You get the beginning of special clinics being set up, or more special clinics being set up. And the people who are interested in this, venereologists, are, as a group of doctors, very bacteriologically laboratory orientated. They rely heavily on the Wassermann reaction for diagnosis of syphilis, and they are using some of the new chemotherapy, salvarsan from the 1900s, and then sulfonamides from the 1930s. Syphilis was very hard to diagnose microscopically and in culture, and so they turned to serum diagnosis, which I'll come back to in relation to chlamydia as well. But in the 1940s, the real turnaround was what was the development of antibiotics. And the WHO Expert Committee on Venereal Diseases, one of the first things that one of the earliest things in 1948 met, and they met in an era of great optimism. That many aspects of venereal disease control has undergone major changes in the last few years. It's penicillin for syphilis. Gonorrhea has lost much of its capacity to injure the humans. Minor venereal diseases have shown satisfactory response to chemotherapy. Culture techniques have improved for gonococcus. There's better antigens for syphilis, and that they see the future really of STI control largely as rolling out these developments to the world. And so this is their future problem, which is that the future should be placed on the control of syphilis, with gonorrhea and other conditions, LGV, in that order of importance. But then they say, in view of reports from many countries on the increasing importance of genital infections of unclassified or ill-defined origin, the possibility of new entities of venereal infections being considered in the future should be stressed. And that's the WHO kind of pointing towards this new problem. And that is, and immediately, almost immediately in 1950, Harkness, who is a South African doctor working as a urologist in London, publishes a book called Non-gonococcal Urethritis, where it's a very long book, it's 300 or 400 pages, where he systematically goes through all the possibilities of trying to kind of unpack what these things are. So he talks about protozoa, metazoa, fungi. It's a really long book about kind of all the possible causes of urethritis. And the impact in Britain is immediate, in that the following year the UK Department of Health starts recording NGU figures for the first time, but only in men. This is not, NGU is not a female disease at this time. It's male only. And everybody is surprised in the first year when the figures are 2/3 of those for gonorrhea. This is a disease which has kind of come from nowhere. Is it something that the troops have brought back from the war? Well, from their war service? Well, maybe, but perhaps it was around in the 1930s. And it continues to be recorded throughout the 1950s. And in 1965, it becomes the most prevalent reported STI when it overtakes gonorrhea in that year. By that time, it's also being known as NSU. But I remember being at school in the 1960s and having talks in our sex education course, being told about NSUs that we thought were German motorbikes. This was not something we took very seriously. But it was a puzzle to STI specialists. Its incidence was rising, but it was relatively easily treatable. But it kept coming back, and the figures were relatively high. And there was growing awareness that it was also a condition in women, but it wasn't important enough to record the figures. But the real puzzle for these laboratory, microbiologically minded venereologists, STI specialists, was that it was a residual category. It was a disease it was a condition defined by what it wasn't. It wasn't gonorrhea, and it didn't respond to penicillin. That was what it was. And so largely the STI specialists began to look at what it was. Was it an infection, or was it just an inflammation caused by trauma, contraceptives? There are a whole range of possibilities. When they turned to infections, the first and most likely candidate was what they called the trick agent, which was the trachoma, the agent that was known to cause trachoma inclusion conjunctivitis. Now this had been, they then started to kind of look at the history of trachoma, and they traced this back to 1905 when I think it was two German doctors working in I think Southeast Asia had actually reported seeing some inclusion bodies, some pathogens that were in vacuoles inside cells associated with trachoma. And by the 1960s, Initially, because these were intracellular, they were thought to be viruses. But by the 1960s, methods have been developed to culture these organisms with using cell culture, and it was clear that they were intracellular bacteria rather than viruses. And they were one and possibly the most likely candidate. And one suggestion was actually that NGU was actually a kind of tropical eye disease brought back from the Far East by troops. But there are a number of other possibilities as well. Was it caused by mycoplasma? Was it caused by fungi? Was it caused by a virus? And this became a focus of kind of great attention amongst STI specialists by the mid-1970s. Robbie Morton, who was a Sheffield-based STI specialist and wrote very senior figure in the field and wrote a important popular book on STIs, talks about in 1975, talks about it still being the most perplexing problem faced in these clinics. What actually was these things? Yet at the same time, there was this sense from a Lancet editorial the year before that the chlamydia genus is in fashion again. This has kind of puzzled me about when it was in fashion before. And the only answer I can come up with is that it was in fashion in the 1890s and again in 1930s in relation to psittacosis in parrots, when it was thought that it was the same organism that caused trachoma. And I mean, particularly in the 1930s, it's quite amusing really, that there was a psittacosis scare in London and in Manchester, to be pointed, in 1928, 1929, 1930, where parrots and other birds imported from Brazil were thought to be carrying this disease, and this caused a panic when the mayor of Ashton-under-Lyne, which is the town near Manchester, died. His son was a GP and he was diagnosed with psittacosis. And apparently then a lot of people who kept birds as pets kind of let them out because they were worried about catching them, and there were parakeets and parrots flying around Manchester and London until the winter called them off because of this public fear about psittacosis. That's the only thing I can see it being in fashion again. But by the mid-70s, cell culture was suggesting on various figures that something like chlamydia was responsible for between 1/4 and 1/2 of all NSU NGU. And they were also beginning to recognize that it was a problem, in women. So what one sees in the 1980s is this category beginning to be broken down. NGU is increasingly reported, stops being reported as NGU. So it continues to be reported as NGU, but there are subcategories within it of mainly chlamydia, mycoplasma, and LGV. And also in the late 70s, gynecologists become interested in what they call at this time the silent epidemic. That they begin to recognize, or begin to claim, that a significant proportion of infertility in women is caused by chlamydia inflammation of the fallopian tubes, that it's also responsible for pelvic inflammatory disease and for a number of other considerations. And they begin to, the gynecologists particularly, begin to campaign for a national culture service and begin to push for chlamydia NGU to be recognized as a disease that affects both sexes. And there's a considerable momentum behind this. I mean, what seems to happen is that this move within STI and within gynecology gets kind of sidelined or put on the back burner because of AIDS, HIV emergence. This becomes the priority for STI specialists. STI clinics kind of develop this as a particular focus. This has the effect, of course, of boosting the size, the power, and the money within STI clinics. And for a while, chlamydia is thought to be a possible cofactor in HIV/AIDS infection, and it's investigated for that reason. But and so you get more investment in STI labs, but also this coincides with molecular biology and the use of a whole new set of techniques for the diagnosis of infectious diseases, which I'll come on to in a moment. New types of staining with fluorescent bodies, new types of antigen, antiserum, and new types of antigen antibody diagnoses, and then eventually nucleic amplification techniques. And I mean, this is partly coming from the new biology, new molecular biology, but also partly that STI clinics now have the labs and the facilities to take on these kind of things. And then by the mid-90s, there is this issue about kind of where is chlamydia? Where does chlamydia belong? Does it belong in STI clinics? Does it belong in gynecology? Or in Britain, we have this new specialism of GUM, genitourinary medicine. And if it is defined by urethritis, then perhaps it should be in GUM clinics rather than STI clinics, or perhaps it's the gynecologists deal with it. But the really interesting thing is what happens with diagnosis, where there are broadly two methods. You can do direct diagnosis. You can actually observe the organism using microscopy or culture. Cell culture, which was the gold standard in the 1960s, and in some countries is still the gold standard in medico-legal cases, is very time-consuming, very expensive, and very unreliable, or very technician-dependent, and is not preferred. There were various attempts to improve microscopy, but the way forward from the 1980s was to try to identify an antibody or an antigen, and it's the development of antibody and antigen tests which has really driven work on chlamydia for the last 20 years. But the problem with these tests is how sensitive they were and how specific they were. To what extent do they give false positives, false negatives? Are they revealing the real infection? This is one representation of the. I'm not saying this is accurate, but this is the kind of debate that goes on about the different sensitivities of the different methods. So that the culture method, which is still the gold standard, only gives about just over 65% median sensitivity, but it ranges between 90 and 40%. And then you get various kinds of direct fluorescent antibody tests through to polymerase chain reaction, ligase chain reaction, and whatever it is, TMA transcription-mediated amplification. And there was a debate through the 2000s about kind of what should be the gold standard. But the problem was the people arguing that the PCR should be the gold standard were calibrating against culture, which was a very unreliable standard, but was the one that was established. And what's happened in the UK is that the government in the 2000s, and I think this is more generally the case, became very worried about the incidence of chlamydia, particularly in women, particularly because it's only symptomatic in 20% of women suffering. It's thought to be asymptomatic in 80% of cases. And I think in men it's, again, something like it's asymptomatic in 40% of cases, or between 40 and 20% of cases. There is this silent epidemic continuing. And if you go to the cinema in Britain, the only STI warnings you receive these days is about chlamydia. It is the highest profile STI. And the government in Britain kind of started to want to know what the level in the general population was. And so they had to evaluate these screening methods. And of course, if you're doing a population survey, you don't want lots of false positives because you're probably only recording a 2, 3, 4% incidence. But if you're doing a diagnosis in an STI clinic, then false positives are probably not a problem because you've already treated the patient before you've got the result back. It's kind of interesting that they use different techniques, different diagnostic techniques for different types of chlamydia where they're actually diagnosing it. The overall figures are telling you kind of quite a different story in this place. So, I mean, chlamydia is a disease without a history, just to sum up. Lots of STI specialists will say, well, yes, NGU was really mostly chlamydia. But actually, NGU can't be chlamydia because NGUs included other things than chlamydia, all these other things. But also, we now know that because NGU, by definition, you had to have urethritis, it was only revealing 1 in 5 cases in women at best, and possibly only 50% of cases in men. So that chlamydia must, is both smaller than NGU in terms of the number of diseases, but probably larger than NGU in its actual incidence. And so that raises the question, and I mean, it would be interesting to have some discussion about how this could be answered. About, is it a new infection? Was it a new disease entity that arrived in Europe in the 1940s, grew to in the 1950s? Or is it just a newly recognized infection that only, nucleic acid, the NAAT methods have actually recognized? I mean, I've discussed this with a demographer, and we would like to get our hands on some tissue samples from the 1850s or the 1900s to see if we could run some DNA tests to actually see if you can find chlamydia in these things. If somebody's got a set of urines or wherever somewhere bottled away, but I think I've seen some actually. I think there's some just over the border if you go to the Pasteur Museum in Dole, there are some flasks there that allegedly Pasteur sealed in 1862 that have still not gone cloudy. So but I doubt if they'd give us permission to have a look to see what the incidence of chlamydia was in Dole in 1862. So I think come back to this question about has there been an increase or not? Is the increase real? Or is it simply a case that the more you look, the more you find with this disease? So I'll stop there. Thank you very much.
Well, thank you, Professor Worboys. I'd like now to invite Dr. Nathalie Broutet, who is the medical officer in the Department of Reproductive Health here at WHO, to give the WHO assessment of the current situation.
Thank you. Okay, good afternoon, and thank you for the invitation and the opportunity to participate to this debate on chlamydia. So I'll take more a public health perspective on the chlamydia infection and what we are doing or what we are not doing in WHO with regard to the control of chlamydia. So just to come back to our previous talk, it's true that since the 80s the HIV has really been a focus as a STI because it was a new infection, devastating, affecting young population. But we must not forget that since before Christ, sexually transmitting infections have existed. There have been very severe epidemic of STIs and affecting anonymous population. But also we know about STI because they affected also kings, philosophers, popes, and very well-known people that were affected by, well, for instance, syphilis. So what I'd like to first to look at STI in general and then to go into chlamydia more specifically. And I think chlamydia being a sexually transmitted infection is part of the of this picture, global picture, how we are affected by STI. So it affects at different level, individual level, sexual partners, or unborn child, that's related to vertical transmission of STI, and at the population level. So the effects at the individual level, it can be acute symptom, as we've just heard, with the symptom like urethritis. It can affect as infertility, cervical cancer, HIV acquisition, neurological and cardiovascular disease with syphilis, and recurrent herpes simplex virus infections. So at the level of the partners or unborn child, so it increases, of course, for the partner STI transmission, and it gives all these possible infections in the newborn or stillbirth for baby that even died before they are born. And at the population level, of course, continuation of transmission and the lack of prevention of STI can also increase transmission of HIV. Intervention, basically there's a lot of intervention to treat the recognized symptoms, and we'll come back to that. But at the individual level, counseling and the use of condoms is the more effective one we have at the moment. So what is the global burden? So in 2005, we reviewed the estimates of STI in the world, and this is the estimate of 4 treatable STI, which include gonorrhea, chlamydia, trichomoniasis, and syphilis. So the total number of new cases in 2005 is more than 400 million. And with more cases in male, and principally due to trichomoniasis, as you will see. And this is the distribution per region. These are estimates based on studies that have been published. So if you look at the STI global burden per sex, so here in women and in men, and per region, you can see that the chlamydia infection is the most prevalent bacterial infections for women, and particularly in the Americas, in Repos and NAFO. So all these estimates are really specific. There are a huge variation of STI according to the region, according to countries, and even in the given countries, where it depends on where you are measuring STI in the countries, and depending on population. And this is because the dynamic of the transmission of STI is really depending on sexual behavior, and that you have different risk or at-risk group in STI. So with maybe the lower prevalence in the general population, but and the high prevalence in high-risk population, as we know with the sex worker, commercial sex workers, for instance, but there are also men having sex with men, truck drivers. So there is some very high-risk population that are really the main transmitters for STI, with the bridging population that could be the clients for sex workers, commercial sex workers, toward general population and toward pregnant women. So in 2006, the WHO Global Strategy for the Prevention and Control of Sexually Transmitted Infections have been endorsed by the World Health Assembly, and the basis of the strategy is really how to break the chain of transmission of STI. So one of the models which has been really adopted and tried to be implemented in regions and in countries is first to work on this dynamic of the transmission of STI. So what could be done at this different level of the population to decrease at the end the HIV and STI incidence? So there is a number of targeted interventions for high-risk population, and also some defined interventions to ensure that the general population has access to the treatment and the management, correct management and screening of STI. So I'd like to come back to quickly to different interventions, and this is really a famous pyramid, inverse pyramid, that has been published by Peter Piot a few years ago, and which explained very interestingly how we lose control of STI. First, because, well, here is the general population, and that's where we can have implement primary prevention. But then you have a population with STI, and most of this population is asymptomatic. So the first where we lose population is that we need to ensure that the people recognize STI symptoms. Then these people need to seek care. That's why we lose also the population. So and even when the patients reach health services, they could be screened and treated, there is some issue with the correct diagnosis, correct treatment, completed treatment, and finally to have a cure, and also have a partner treated that could prevent reinfections. So that's how we lose. And finally, among the population with STI, we manage, it's not proportional and it's not to the scale, but we have a very small proportion which are of population which is effectively treated and managed. So what can be done at the general population level? First is promotion of healthy sexual behavior and condom use. And for that, it's very important to use, to have good communication skill, to use peer educators, and also to explore work with schools and what the role of school in sexual education to prevent STI in adolescents. We don't have vaccine for STI, at least for bacterial STI. There is only 2 vaccines available with viral STI, which are the hepatitis B vaccines and the HPV vaccines. HSV2 and HIV still in clinical trials. So really the primary prevention should be based on sexual health education, condom use. In terms of recognizing the symptoms, seeking care, and having correct diagnosis and treatment, for the symptomatic population, the difficulty is about the screening test. So what WHO promotes for years is really the symptomatic approach. So you treat the patient on the basis of the syndromes which are expressed, with the limitation of that you only treat symptomatic infections. So and this is working at least for some of the symptoms. This is not a perfect approach, but if at least all the symptomatic patients could be treated, that would be a great advance. However, we've got some drawback of this approach and also of the different treatment approach for STI, which is the increase of antimicrobial resistance to gonorrhea. And to the point that quinolone is not recommended to be used anymore for the treatment of gonorrhea in many countries, and monitoring the trends of resistance is quite an important component of STI control strategy to ensure a correct treatment for the patient. With respect to asymptomatic STI, we've got some partner notification, screening, and case finding are the issue. With regard to screening, and I'd like to link a little bit with what our colleague just mentioned with chlamydia, we have many tests available and good tests and very sensitive and specific. But the issue that for screening of population or pregnant women or population coming to health service, we don't have point of care tests that could permit the screening, diagnosis, and immediate treatment of the STI, and also that would be at a low cost that could be available in low-income countries or middle-income countries. So there is still a lot of work to be done at this point. And just to come back, I mean, to the point that most of the STI are asymptomatic, where you can imagine the need for these tests to be able to screen an asymptomatic population that we can have a correct treatment. And then I try to make the bridge then with the chlamydia infection, because this is really the infection which is the silent disease, asymptomatic. 70% or more of the cases of chlamydia are asymptomatic. And this is the total number of estimated cases of chlamydia in 2005. which is about more than 100 million of new cases in the world, with, you can see, a large part in Repro and in Afro region. And this is the age and specific rate of chlamydia infections. In the Repro region, you see that this is the prevalence in young population, 25 years old and more, and in light purple, this is in a younger population less than 25 years old. And you see the difference of prevalence. And you see the same image in Ireland. This is study between 2001-2006, and you see the high prevalence of the infection among women in 2024, 15, 19, and then decreasing at the age. This is the USA in 2006, also a very large increase, a very important incidence. These are incidents of chlamydia infections in 15, 19, and 2024 years old, and much more important in women than in boys. So what are the issue with chlamydia infections? First, it is the long-term consequences of these infections with, on the reproductive tract, with pelvic inflammatory disease, tubal factor infertility, and ectopic pregnancy. And the aim of the control program is to try to decrease the number of adverse outcomes of these infections. So first, these control programs that have been put in place in the US and also in a few countries in the Western Pacific region aim to reduce transmission with the key intervention I was mentioning for any STI, but also trying to screen asymptomatic infection in the young sexually active women, to treat of course the woman depending on the result of the test, to treat male partners, and importantly to screen women for reinfections. The impact of the individual level of this strategy really depends on different factors, which is a quite complex issue for the impact of the program. And it depends on the damage that has already been done on the linked to the acquisition of the infection. So if, for instance, the tubal damage was very important, then the treatment of the infection may not have impact on the outcome. And this depends also on the mean duration of the infection at the moment the woman is screened. So, and we've observed also that, and you'll see in a slide later, that we observed a recurrence of infections after screening and treatment. So, the impact and the impact of the treatment depends on the benefits of the treatment of the infections, and also of the susceptibility that could follow this treatment with new infections, and consequently with a new risk of sequelae. So this is why the rescreening part is important when you've treated already a woman for chlamydia. And at the population level, of course, the importance is to reduce the transmission, so reduce the number of infections, decrease the number of new infections, and reduce the complication. But this impact and the impact on the decrease of the outcome of the decrease of the complication of chlamydia infections, and the potential increase of repeated infections really depends on the success of the partner treatment and of rescreening program. And this is really what has been observed. For instance, you look, this is this data from the Connecticut state in the United States, and they looked at the recurrence of infections after an initial treatment. And what you look at, this is the age at diagnosis, so between 13 years old and 21 years old, and this is the percentage of reinfection after a first treatment and screening. And the recurrence rate, I'm not sure, the recurrence rate here are almost, and even sometimes as high as the initial rates of infections. And the issue is to understand, well, first, are the partners have been correctly treated. How the timing of treatment was a bit too early in age, and we didn't leave the chance to the infections to get cleared. There is the issue of the consistent and correct use of condom. Is there any misperception in terms of risk for sexual relationship? So all these need to be carefully addressed when we start a specific program to try to control chlamydia infection in young people. And also, you know, there is this well-known inverse relationship between the age and chlamydia infections and STI in general, that, you know, the younger you are, the more at risk you are, in fact. So there are some biological factors like cervical ectopy and some data on the bacterial load of the organism, and also behavioral, behavioral factors like risky sexual behavior, the number of partners, and the interval between different partners. So this is also, I don't have the age group for that. These are pregnant women coming to the antenatal care, and this is a systematic public health program which was implemented in Vanuatu, so in the Western Pacific regions, and the systematic treatment was based on the prevalence. The prevalence is in the population and in pregnant women was more than 20%. So that was the threshold, and every pregnant woman would receive a treatment for during that pregnancy. The partner was treated, was given treatment, but that was difficult to find. Sometimes, you know, the partner was not treated, and to find all the partner may also be an issue. Then the problem was the rescreening. They used some new tests and PCR based, but there is an issue with the capacity of the laboratory structure, the staff, and all the coverage of and the access to the screening. So what you observe is that in 1999, prior to the implementation of the program, 23% of pregnant women were infected. Then the impact and the treatment, systematic treatment, was about reduce the prevalence of 10%. But then you observe a few years later a rebound of the chlamydia infection among pregnant women. And you know that the same image that we've seen in the young population before in the US, and we always observe this phenomenon. And this is certainly linked to the difficulty of the treatment of the partners, also the rescreening, the retreatment, the frequency between the screening, but it's also maybe other mechanisms that we don't really control. So that's for younger, for older or younger or older women, there is specific also targeted intervention that may have an interesting impact. For example, that's the outreach, of course, and education, as always, the essential component of STI control. And the 100% condom use program, which has been shown to be quite effective, and it's really focused on the male partner of commercial sex workers, so that they use condom, and the access to STI services with the initial presumptive treatment for chlamydia, including chlamydia, and a regular checkup. And you know the initial, this is the baseline. And 6 months after, so we observed the decrease. Really, that's the consequence of the program in China. But we have similar slide from the that has been given by Theodore Howie from the Western Pacific region, and we've got quite an important decrease few months following the implementation of the program. And again, we don't have the follow-up yet, but you know, again, it seems that there is an increase, a re-increase in the infections. Here again, it's in Filipina, and they see the impact of presumptive treatment and condom use, which show that immediate, 1 month after the initiation of the program, we had an important reduction in chlamydia, and then a rebound, and in many groups, in many different groups. So intervention for young people that we recommend would be the screening and rescreening of previously infected person. If we have the possibility really to maintain the rescreening, retreatment, and we have an idea of what should be the frequency of rescreening. Health education, number one, that is mainly the major issue that can be implemented, and access to services, and also, the adolescent health services, and strengthening surveillance. We certainly need more data on chlamydia. We need more data by age and by sex, and that's a component that we don't always have, and by and more information from different countries, because it's really the chlamydia issue is not only from low-income countries. We observe this difficulty from high-income countries and low-income countries. So the main issues to finish is really the sustainability of the interventions to maintain impact. And when we start, and again, I think it's very important, if there is a program to be started somewhere, is really to ensure that there is the possibility to maintain this screening. So that means to maintain the quality assurance, the quality control of the tests that are used, to maintain the procurement of the tests, to make sure they are available and that the treatment is available. Otherwise, it's not worth to start on a program. And it needs to be also to invest in preventing reinfection. So that's really the key issues, and above all, that will certainly our major piece for controlling STI, that the use of condom, with all the difficulties we know about that. So I'd like to thanks a lot first Sami Gottlieb, who has been very inspirative by publishing this special issue of the Journal of Infectious Disease. So if you're interested in chlamydia, I would recommend very much to read it, and also that in which they highlighted some research needs that could be quite important to understand better these chlamydia infections, and which is mainly, I think one of the main issues would be the availability of point-of-care screening tools at a low cost, but also to understand better the infection clearance and persistence, because we may be in the same situation. Well, I can relate to that, but to HPV infection, the human papillomavirus, where it's not worth to screen too early because there will be a natural clearance of the infection. So that would be very important things to understand. The pathogenesis, what would be then the consequence, and the link to the infertility, so that's something we need also to understand better, and the protective immunity. And I want also to thank Melody Marouf, our intern, that helped me a lot with the presentation. Thanks a lot.
Okay, well, I'll hand over the coordination now to my co-organizer, Dr. Sanjay Bhattacharya from the University of York.
Thank you. Well, thank you for two thought-provoking presentations. I think the second paper particularly hinted at resistance and at some of the options, or some of the options that are available to us. I'm wondering, Mick, in your study, you told us, gave us a wonderful description of the development of knowledge about chlamydia through improved research and screening. Were there people questioning this new knowledge, which is always interesting, and on what basis? Was this new knowledge threatening old specialisms in any way? Again, Nathalie, I wonder, in relation to chlamydia, within the WHO, is it only one department that works on it, or again, is it different departments guarding their territory as there is a search for an integrated fight against the disease? So we're very grateful. Some insights, please.
Just to answer the first question about new knowledge, there was certainly competition through the 1960s and 70s about actually what the agent was. Different research groups invested in different claims about about the nature of the agent. But there was reasonably quick consensus about that it was Chlamydia trachomatis. I mean, partly because of the new technologies that were enabling more accurate diagnosis and greater reliability. The problem earlier with cell culture was that it was just very unreliable and very expensive, and not many labs actually did it. Some of the new labs, partly because of the HIV investment in STI labs, meant that these new tests were quick to roll out. In terms of the testing, then there was enormous competition between the new biotech companies. I mean, Roche and various others, Gentech and various others, kind of promoting these tests. And more recently, there have been a number of people who've claimed to develop point-of-care tests, but there's dispute about there is dispute about their reliability. And the only other kind of not so much competition. But there were different groups. As I said, gynecologists were kind of thinking that it was should it be their disease rather than STI clinics, and then this new entity GUM taking over from well, I don't know, taking over bits of gynecology, but maybe not. So yeah, I mean, but no, I think the argument was that people were concerned that this was a silent epidemic in women, and the recognition that 80% of women were asymptomatic, and that this was just being missed. And this coincides, of course, with the arrival of infertility, as the medicalization of infertility as a problem, and the kind of greater investment and recognition of infertility and how one might do about it, and tubal infections and other things as a cause of that. So no, I think there was a kind of consensus around that this is a really serious problem, and particularly because it chimed in the 1970s with the women's health movement.
Thank you.
Okay, so in WHO, so the STI control in WHO is mainly within one department, which is reproductive health and research. So that really is it was in HIV before, and then it moved to the reproductive health and research department, which gives a great opportunity, in fact, to integrate all the issue around the long-term complication of STI and issue of STI control in the sexual and reproductive health agenda, which is really important. And STI control is also part of the sexual and reproductive health strategy for WHO. But we are not working, it's a unit, and we are working a lot with the HIV department. There is lots of linkages established with regard in particular for the prevention of mother-to-child transmission of HIV and syphilis. And I'm glad that already in 1948, WHO highlighted syphilis as a key issue to be addressed in terms of STI, because we still think the same today, so I'm not sure what were the progress. But we've got quite an initiative on prevention of mother-to-child transmission of HIV and syphilis, so lots of linkages. And also with the mother and child and newborn and adolescent health department, because we really want to focus some of the STI control strategy and sexual health strategy for adolescents, because you've seen that there is an issue with adolescents that we don't really understand that we can control. So.
Question and answers. Shall we start, Madam? And can you please identify yourself for the webinar attendees?
Hi, thank you for coming. My name is Lori Newman, and I work with Natalie in the Reproductive Health Department on the STI team. I enjoyed your presentation very much. It's fun to think back and understand better these ideas, and we often don't spend enough time thinking about where we came from while we're thinking about where we need to go to. One thing that I'm curious about, when you showed your graphs of the STI, you were showing gonorrhea, chlamydia, and syphilis in the UK. What do you know about monitoring systems in the UK? Couldn't you also be looking at PID and infertility? Are there any data sources that you could also be looking at the sequelae and the impact to help you tease out and better understand this question and look at over time what is happening to these the sequela, are there, and would that help you untangle in any way? Of course, it gets confusing with what to do with the gonorrhea, but it could just add another perspective to add in if you're able to do that in any way. And then I'm also wondering if, they've done, in terms of syphilis, historically, it's been a little bit easier over time, and we know about syphilis in ancient history because of the bone deformities and teeth deformities and so forth. But I am wondering if whether some of the nucleic, the PCR technology could be used on mummies or any kind of tissue specimens that are remaining. I'm not sure how effective they would be, but if you could go back in time and look.
Well, I mean, just to make a comment on the second question first. One of my colleagues in Manchester is, I think he calls himself a bioarchaeologist who works on kind of ancient DNA, and he was telling me a couple of weeks ago that until quite recently you actually needed human tissue, or you needed bone, or some actual kind of bone washings or something to actually recover enough DNA to do something. But he was now saying that they're now beginning to work on grave washings and being able to pick up DNA from things. And I mean, interestingly, I said, well, what are you finding? And he said, well, we're finding a lot of mouse DNA. So it might be, I think the sensitivity and the speed and the accuracy of the test is increasing so much. I think there is some quite exciting potential in this bioarchaeology field coming up. I mean, in terms of correlating chlamydia and gonorrhea with PID, etc. I mean, I don't think, as far as I'm aware, the government doesn't collect that data because it's not part of any surveillance system. And of course, it would then depend on reporting criteria and reporting accuracy. And I come back to the question about, what is that? What is the upward line of chlamydia telling us? Is it simply telling us that they're now able, because of improved tests and reduced costs, to actually run more tests at STI clinics, whereas they couldn't do that in 1998. So I think I think that interestingly, I didn't have time to put the figures on, but the chlamydia incidence has actually declined. It declined in 2009 and again in 2010. It's kind of leveled off. It leveled off in 2009 and has declined for the last couple of years, but not significantly. And one interpretation of that is that the testing regime is now stabilized, and that is what that is picking up rather than any chlamydia control. So I think with all particularly with this data, and particularly because the testing regimes and who's tested and how they're tested has changed so rapidly in the last 10 years. I think any data is unreliable on chlamydia incidence, and we don't have. I'm not aware that we have the PID and ectopic pregnancy data.
Hello, my name is Cheryl Vanderpool, and I'm also in the Department of Reproductive Health and Research, and I'm the focal point for infertility. So therefore I'm quite interested in actually the question that Laurie had for you. One area where you could potentially get this data is from the HFEA, which monitors and looks at infertility interventions. However, that would only be evaluating patients who've come for care, which is why I had one question for you and also one for Nathalie. And the question for you is, it's interesting that as a historian you had not brought up the issue of sexual experimentation that was occurring in the late 60s and 70s, which has often been linked to potential increase in sexually transmitted infections. So I just wondered whether or not you've linked that. The other question I'd like you to consider and to think about is, I found it very fascinating in that you've done a division, which unfortunately has been done by us and others, separating HIV from STIs and gum, in a sense, from HIV. And so this decompartmentalization is worrying, especially if, as mentioned, they seem to be coexisting, and there may actually be some co-infection and increase of HIV due to existing. So if you could address that, please. And then for you, Nathalie, I'm really interested in why we're only looking at these young populations, because, and the interest that the high reinfection rates of these young people in their 20s, and yet the amazing decrease in older populations. Yet it is in these slightly older populations where we are seeing the effect on infertility. And if the argument is don't test too early because they may clear, the question is the damage may have already been done on maternal morbidity, which would result in these women having infertility, men having tubal problems as well, and ectopic pregnancies. So if you could please respond to that. Thank you.
The second point first. I mean, I wasn't making the separation. I was reporting the separation. So I think that's well, that is. But of course, the problem is that if you try to aggregate the data, then they're reporting them in different ways, and you don't know whether you're double counting someone who went to an STI clinic and then was referred to a gum clinic, and you know, went to an STI clinic, found they were pregnant, and ends up in gynecology. So that it's kind of there's issues about double counting. I mean, in terms of the impact of the 1960s, you do see a small increase in gonorrhea and syphilis in Britain, but it's relatively small because it's kind of so readily treatable, or people regard it as treatable. I mean, I was around in the permissive 60s. Like most people who are around, don't remember them being that permissive. But there was a perception. There was a perception about if you got one of these diseases, then you would just go to the doctor, get an antibiotic, and it would be over. They weren't. You know, syphilis had lost its scary things, and it was just a kind of occupational hazard of being a student.
But not for non-symptomatic chlamydia.
No.
That was the issue.
Yeah, but that wasn't being diagnosed then.
But you were saying there was this major increase, and was it due? I liked your question. Was it due to testing?
Yeah.
Yeah, or was it due to perhaps?
But then it always struck me that if it's to do with changing behaviour, then why doesn't gonorrhea follow chlamydia? Because it's
different
because
bacteria.
gonorrhea was being treated.
Different,
yeah, I know it's different bacteria,
different hosts, different. You know.
And it was being treated.
Yeah,
so your transmission.
Oh yeah. But also, I mean, there's also the point, isn't there, that the general use of antibiotics in the population would be treating undiagnosed disease.
Absolutely.
So the more you're treating throat infections with broad spectrum antibiotics, you're also treating other infections as well.
Cheryl, well, you always have difficult questions, but I mean, you're right, but the problem is at what age, I mean, for high-income countries, I mean, most of high-income countries, some of them have a chlamydia control program targeting adolescents, and they manage to screen, to treat, to rescreen, and to treat partners, so they can observe a little sort of impact, even if they have some recurrence rates. So, but they have recurrence, but because they can observe the recurrence, they will screen and they will be resistant. Now, in fact, we have a lack of evidence here of what is the long-term impact of this treatment. You know, and maybe we are even. The question is, by treating early, do you stop an immunogenic process that could have a positive impact of the development of or protecting from reinfections or toward the development of complication. So it's all that is unknown, and it's linked to, I mean, again, that's as for any infectious disease. It's linked to the host, it's linked also to the strain. There are some studies on different chlamydia strains that have different impact on pathogenicity. So this is quite an issue, and we really don't know what to do. So I mean, for low-income countries that cannot maintain a rescreening program, I think the only thing we can do is prevent the infection by using condom.
Yes, and sadly, the highest rates of infertility are in developing countries, low-income countries, with the greatest etiology due to tubal factor.
Yeah.
And the only way to treat tubal factor is with IVF or tubal surgery, both of which are totally out of reach. So if we can't address chlamydia in these countries and we can't address infertility in these countries, I mean, we're not doing anything.
But I mean, I have a question now for you. I mean, this separation of categories, did it happen just in the WHO, or did UNAIDS and its arrival also have a role in that?
I'll let Nathalie take that question.
Which category?
You know, separating chlamydia from AIDS, you know.
Well, I don't think it matters too much where it sits. No? The importance is to try to have these linkages in place and where we can be complementary. Mm-hmm. And that's what we're trying to do. I mean, you know, what has impaired STI control program at Whitepod is because there was the study that were published on the impact of STI treatment on HIV transmission acquisition didn't show a real effect, in fact. So that was said that, you know, STI treatment, STI control didn't matter for HIV. But, but you know, beyond that, STI prevention, HIV being an STI, STI prevention will impact on HIV. So we've got to have common approach to that, and that's sexual health.
Is there a common approach between WHO and UNAIDS?
Yeah, I mean, UNAIDS is a coordinating body of the different agencies working on HIV. So yes, there are common approach, absolutely. And I think within WHO, what we need to do is to find the complementarity expertise between the different units so that we can address the problem. I think. Sorry, because I'm done.
One was on the asymptomatic chlamydia. And what is the evidence that, in fact, that is related to infertility? I mean, is there any actual evidence on that? And for the moment, I forgot my second question, so I'll if you ask that, I'll try and remember what my first question was.
The short answer, I think, we don't have that much evidence, and we really miss some data on the pathogenesis of chlamydia. That's really what we need, and the difficulty that on a human model is difficult because, you know, ethically you cannot leave an infections evolved, and the difficulty, I suppose, is to try to find a good animal model that is close enough to human being to try to understand the pathogenesis of chlamydia. But no, we don't know. Do you have any idea? Sure, you may have, because there was this review that you followed up that was done, so there may be some elements on that, no?
We attempted to do a systematic review to evaluate the linkage between chlamydia infection and infertility. And sadly, the field of infertility was and had been very low in priority across public health areas. And it also dropped off many of research agendas of both WHO and funders. Luckily, it's coming back on, and we are moving more forward as we see that it's really very integrated into to maintain a more holistic approach to sexual and reproductive health, both for HIV as well as STIs and other aspects, even unsafe abortion issues, which also lend to infertility and could also increase possibilities for other STIs. This is something that we recognize as a huge gap, a huge research gap, as mentioned by Nathalie, also looking at pathogenesis and the effect. So to answer your question, no, we don't know the answer to that, and as it is a silent infection, it's very difficult to follow. Thank you.
My second question. If we assume that chlamydia actually isn't an ancient infection and that is something recent, then is there any ideas of where it may have come from?
The simple answer is no, but there's one interesting statistics, which is that nobody here today has mentioned trachoma. And I remember years ago going to Ellis Island in New York and listening to the presentation, and the presentation was very good, and I put my hand up at the end and said, well, how many people were sent back? How many people were turned around at Ellis Island and sent back to Europe? And apparently it was 2% on average. 1% on legal grounds and 1% on medical grounds. Now, a lot of people with infections just went into the isolation blocks there, and they were then allowed in later. The single largest cause of turning people back was trachoma, and this was, whether it was trachoma or whether it was just it was a visible eye infection, and it was somehow people were stigmatized by having pussy eyes or whatever. But it always struck me that was quite an interesting statistic. And one kind of local reason why one picks this up is that people sent back from New York usually ended up in Liverpool, because if you were coming from Eastern Europe, it's a bit like traveling today. If you were coming from Eastern Europe, say you were leaving one of the German ports, it was cheaper to get a boat to Hull, get the train to Liverpool, and then go Liverpool, New York, than it was to go Hamburg, New York. So there was, and so a lot of the infected ended up in Liverpool, and the Liverpool health authorities had to deal with these people, and obviously they tried to put them on a train back to Hull to get them back to back to Eastern Europe again. But it does suggest, if it was trachoma, then maybe that suggests that there was this. And of course, but again, that's, from the work I've done on the work I did on gonorrhea. Of course, in 19th century blind asylums, the estimate was that about a third of them were due to gonorrhea, and that it was actually only from whenever it was 1885 when they started irrigating babies' eyes with silver nitrate that the incidence of ophthalmia neonatorum actually started to go down. Now, I don't know whether silver nitrate would also destroy any trachoma infection. I don't know. So I think there's interesting things to pursue in those lines, particularly with the Ellis. I haven't had time to do it, but it would be interesting to go. I think it would be interesting to go back and look at the Ellis Island data, because people who've written about that there's been all the fuss about the things that immigrants were put through, but actually 98% got through.
I have one other question to our historian. And you were saying that the chlamydia was mainly picked up and was only considered a disease in men, or many of these diseases. Is that perhaps also due, again, to segregation in urologists versus gums? Are urologists also, male urologists, part of gums? Just curious. Or is that a female? Just I was curious.
Yeah, gum is increasingly I think what's happening in Britain is that obs and gynae is becoming split, and gynae is going into gum. So gum is a kind of both-sex operation, and obstetrics is becoming separate. And people have campaigned for that for ages because of the link. Why link a disease specialism with a natural birth specialism? So I think that's the case. The problem with the problem was it was defined as urethritis. I mean, people weren't looking at the cervix or anywhere else for swabs or wherever. So as long as it was urethritis, then it's men. So it's very simple.
So maybe that's also your increased rate, is you now have increased because now it's women, it's not just men.
Yeah.
So you can double and then.
Yeah, well, those. I mean, since those figures, which actually start in '93, they are both sexes. Yeah.